Hi everyone, I'm Neal Jones. I'm a third year medical resident at UCSD, and I wanted to talk about a pretty interesting case that I had while I was on wards. So I had a 21-year-old Ethiopian woman. She had no past medical history who came to us with several days of high-grade fevers and tachycardia. When we got more of the history, we noticed a kind of a linear path in how her symptoms developed. With about 2 months prior, she developed these hyperpigmented lesions on her arms, started spreading to her legs, and then around a little after this, she started noticing some fatigue, malaise, and even weight loss, followed by high fevers and night sweats, which prompted her to come into the ED. So when we eventually saw her, she was febrile up to 103. She was tachycardic into the 140s. Given this, her physical exam was remarkably unremarkable. Really, only we could find these hyperpigmented patches on her arms and her legs that were flat, smooth, and just kind of had some nodularity underneath. Her labs were really only significant for like a pancytopenia, although her platelet count was normal. It was significantly lower than her previous CBCs. She had a lymphopenia, normocytic anemia, an AST elevation to about 158, and albumin of only 2.3. So given the fevers, we thought maybe this could be infectious, and so she was started on broad spectrum antibiotics, but really didn't make any difference. Where you can see on the left, this temperature curve showed that she just continued to spike fevers throughout. And on the right, her heart rates throughout her admission continued to remain about 120 on average, but it went up to even 180. So we thought maybe this could be some sort of odd infection or maybe autoimmune, but really everything was unrevealing up to that point. We decided maybe this could be HLH, or maybe this could be a malignancy. And surprisingly, her LDH was elevated, her ferritin and IL-2 were also elevated. Early on into the admission, we actually decided to get some imaging. Given her tachycardia, we thought maybe this could be PE, and surprisingly, we were correct. We had seen that she had multiple PEs through multiple segments that were definitely contributing to her heart rate. Uh, Interestingly, though, we noticed that she had this weird fat stranding throughout her chest. So we went ahead and decided to get an abdomen and pelvis on top of that, and we noticed that she had this diffuse subcutaneous fat stranding throughout, not only her chest, but her abdomen as well. We decided we needed to see what was going on in there, and we eventually got an excisional biopsy. And in below, you can see that the results of the skin biopsy. And so the most important thing to make out is there are these areas of adipocytes. So she has adipocyte lobules. And as you see on the top slide, and she had this lupus-like hyaline fat necrosis. So kind of just these areas of fibrosis surrounding the adipocytes. And in the areas of inflammation, what we noticed that there was a ton of lymphocytes that stained positive for CD3 and Ki67, indicating that these were T cells that were highly proliferative. Putting all of this together, we found that she had subcutaneous panniculitis-like T-cell lymphoma. Now, subcutaneous T-cell lymphoma is fairly rare. There's an incidence rate of only 1.5 per 10 million persons, and it wasn't even really considered a diagnosis until about 2001, and has undergone multiple revisions since then. Interestingly, autoimmune disease is only found in about 20% of these patients, but that's enough to think that this lupus-like hyaline necrosis really does have an association where you see SLE pretty frequently. The median age of diagnosis is about 36, and women are about twice as likely to be affected. And the presentations are very similar to how our patient presented, where they have these weird nodules that develop, and then they sometimes develop B symptoms. Some of these cases can be pretty complicated, where they can get serosal effusions, and similarly cytopenias like our patient, and in rare cases HLH. Um, Good news is the prognosis for this is actually pretty good. 5-year survival rate is about 85 to 91%, but if you do develop that HLH, you have a significantly poorer prognosis overall, with a 5-year overall survival of only 46%. When we try to get diagnosis of this, though, it's made very similar to what we did. We got an excisional biopsy, and that's how you should do it. But you could do a telescoping biopsy as well. And you're looking for the CD3 positive, and you can go a little bit further and get CD8 positive as well, and TCR beta, kind of rimming these adipocyte lobules as we see in ours. And so really what you have to think whenever you find this diagnosis, it can mimic a lot of other diseases, and so a lot of skin diseases. But when you think about it, you should also think autoimmune conditions, and it should be ruled out. There's really no standard of care in this. It can be many cytotoxic chemotherapies, but now they're kind of leaning towards only one or two. And so you should think about that when you diagnose this.